Good evening all. I bring regards from Dr Medical College. Respected Chair, my teachers, Madam Manon, Dr. Nalini, Dr. Renu, my colleagues, friends, ladies and gentlemen. My topic is very simple. It's a absolutely ultra short discussion of hypoglycemic disorder. Hypoglycemic disorder is such a common issue. Whatever be the level of hypoglycemia, it's a very common issue in our clinical practice. If you want to get a good control on diabetes mellitus to a tune of 7%, 100% of these patients will develop hypoglycemia. And if you look into the UKPD's data and DCCD data, all these studies showed significant hike in the number of hypoglycemic disorder. But for today's discussion, I am not at all touching on diabetes-related hypoglycemia. I will be discussing 3 interesting cases which we had some experience from Dr Medical College. That is my plan of action for today. First case is a 60-year-old male patient. He was having some sort of behavioral problems, and initially that was relieved with taking some food stuff. And one episode of severe, probably you can call it as class 3 hypoglycemia, and patient had to take intravenous administration of glucose. And patient wanted to prevent these episodes, and he was taking lot of carbohydrate containing diet also. And it is reflecting his weight also, because he is having a weight gain of 10 kilograms. Clinical history and examination did not reveal any positive stigmata or clue regarding the diagnosis. And specifically speaking, there was no evidence of any drug intake, or he was not taking any or features suggestive of adrenal insufficiency. He was not an alcoholic, and none of the family members having diabetes or other issues by which you can select oral drugs which can produce hypoglycemia. And this was a routine clinical evaluation which showed evidence of low blood sugar as evidenced by 52 milligrams of blood sugar, and cortisol was 14.8, otherwise it was okay. So in short, it's a case of hypoglycemic disorder. See, if you discuss something related to hypoglycemia, I think it's better to remember this gentleman. He is having a lot of experience and he only introduced the terminology of Whipple's triad. What is this Whipple's triad? Patients are having symptoms suggestive of hypoglycemia, documented hypoglycemia biochemically, and resolution of symptoms after taking carbohydrate. That is what is known as Whipple's triad. This is one of the prerequisites for evaluating a patient with the hypoglycemic disorder. Let us look into the causes of hypoglycemia. You can divide into 2. The patients are having some sickness or ill-looking issues, which I am not discussing for today. And second subset is absolutely maintained patient or normal patient, looking normal. So sick patient, there are important 4 causes for hypoglycemia. One is renal failure. Second is hepatic failure, severe infections, and cardiac failure. It's a big 4 which can contribute to hypoglycemia. I'm not discussing that also here. This is my trump card today. Patient is having normal, looking normal, and well-preserved patients. What are the causes for that? One cause is insulinoma. Of course, it's a rare situation. There are other tumors also, antibodies to insulin, and endogenous hyperinsulinemia. Lot of things are happening, and which can produce hypoglycemia. Now, what would be the investigation of choice for these patients? So first thing, you are documenting hypoglycemia by looking at the blood sugar, and you are establishing or clearly establishing Whipple's triad also. After that, almost all endocrinologists, they are all looking for 72-hour fasting test. But only one sentence or very important carrier message, please, for heaven's sake, please look into the basal or random C-peptide and insulin. Always we should look into the relation between sugar and insulin. Very important message. Now, coming to our patient, we did 72-hour fasting test for this patient, and he developed hypoglycemia within 4 hours. Blood sugar documented as 28 milligrams per deciliter. what is the corresponding insulin for this type of patient? If the blood sugar comes to less than 55, the expected is maximum is 3 microinternational units per ml. For our patient, insulin level is 11, and CPEP, 11 means what? So patient has got some abnormality in the pancreatic level, and C-peptide is also pretty high, sky high I would say, and urine acetone is normal. We could document a normal cortisol profile also in this patient. So that established the diagnosis of endogenous hyperinsulinism. What is the evidence? Sugar is low, high insulin and high C-peptide level. That established the diagnostic label of endogenous hyperinsulinism. And next investigation, either you can start with the basic investigation like USC abdomen, and you can go for CT scan or MRI. We did a simple investigation CT scan which showed a growth in the uncinate process, as you can see here. And you can go for other investigations also, PET scan, extendin, and which also showing evidence of a growth in the uncinate process of pancreas. So that established a diagnostic label of insulinoma. And basically insulin, a very rare situation. I remember, Pramod may be remembering all those things. We had a very short presentation in ASICON 1995. I still remember those days. Insulinoma is a very rare situation, usually occurs in the 4th and 5th decade. Sometimes very small percentage is associated with the multiple endocrine neoplasia, and CT, ultrasonogram, MRI, which will pick up the growth. It's around 85%. And we are doing a study also regarding the utility of endoscopic pancreatic ultrasonogram, and we used to take the sample also from the growth, which has got a very good sensitivity of around 95%. Of course, you can go for PET scan also for localization. This is our simple, probably very short experience for the last 2 years. Most of the patient had hypoglycemia and weight. You can concentrate on the right side. Patient was having overweight or obesity, and sugar was ranging from 35 to 52, and corresponding insulin was again 2-digit to a tune of 30 or 40, something like that. And C-peptide is also quite high, and most of my patients in this cohort, they develop hypoglycemia within 2 hours. And if you look into the imaging characters, most of the patient we could document growth with the MRI or CT scan, and limited experience with our endoscopic ultrasonogram also, which also very useful for our patients for localizing insulinoma. Now we look into the evidence of multiple endocrine neoplasia. Obviously nothing was there, and we took the patient for surgery. We enucleated the growth, and now the currently patient is absolutely fine, no symptoms of hypoglycemia. Patient is very good. Now this is the first case, a case of insulinoma. Of course, you can get this type of cases in clinical practice also. Now coming to the second case, my dear friends, is a female, and patient was having multiple episodes of hypoglycemia. The lowest recorded blood sugar was 32 milligrams per deciliter. And look at the right side of the chart. You can see here patient is taking multiple drugs, including clopidogrel, atorvastatin, all those things for her vascular problems also. Now, in 2015, this patient was evaluated in Cochin city, and that time they could pick up a growth in the pancreatic region, and after excising the growth, they could see evidence of neuroendocrine tumor size, which already it's around 1 centimeter. But there was a suggestion of another growth somewhere to a tune of 0.2 centimeter, and we could not do insulin staining also. So we feel that in the patient has got a neuroendocrine tumor. Is it insulin producing or non-functioning? We were not sure, and eventually patient disappeared from there, and again patient came to our department in 2017. We did investigation, usual investigation. We could not complete the investigation as usual. We lost the follow-up also. Now, in 2022, patient came to our department again with the same issue. So how to evaluate this patient? We thought and we'll go for as a fresh case. We have documented a hypoglycemia as evidenced by classical Whipple's triad, and 72-hour fasting was performed, which showed evidence of hyperinsulinemic hypoglycemia, and we looked into the C-peptide and proinsulin also. And finally, the right side of the chart shows the evidence of endogenous hyperinsulinemia as evidenced by 38 of blood sugar, and insulin level is pretty high, so 4 digits, usually not seen in case of insulinoma, and C-peptide is also very, very high, cortisol profile is normal. So what could be the diagnostic possibility in this type of cases? You can read the causes like this: insulinoma, very rarely pseudoblastosis, oral drugs, oral hypoglycemic drugs can produce, and lastly you have a situation known as IAS, insulin autoimmune syndrome, or Hirata syndrome. Probably the clinical picture is fitting with the diagnosis of Hirata syndrome. So we thought we will go for the further evaluation by using PEG precipitation method. And you can see here as a clot you can see in the test tube and supernatant solution. What we did was, what we got the report is insulin level is quite high, and pellet also showing very high levels of insulin level, and insulin antibody was also positive. That gives a diagnostic label of insulin autoimmune syndrome or Hirata syndrome. Basically, this is one simple investigation. By simple investigation, you can pick up Hirata syndrome. That is the level of insulin and C-peptide. Very useful. If it is higher than 1, that indicates probably you are dealing with the insulin autoimmune syndrome. Basically, IAS is a hyperinsulinemic situation. Usually, antibodies are positive. No exposure to exogenous insulin. No pathological abnormalities detected in the pancreas. Now it's common in Asia, and most of the cases are both sexes equally distributed, more frequently over 40 years, and immune-mediated hypoglycemia, which develops usually after some triggering factor. What are the triggering factors? Maybe drugs, maybe antithyroid drugs, or alpha-lipoic acid, and there are other drugs also. And there is a strong link between HLA also. Very interesting phenomenon here with IAS is sometimes they can go for hyperglycemia, sometimes that will produce hypoglycemia. You will get confused. So clinical suspicion and observation is very essential to pick up the issue. So what are the causes of the Hirata syndrome? You can see n number of drugs. Even a postgraduate student can't remember the exhaustive list. And please remember, on the right side, there are certain autoimmune phenomena also which can produce hypoglycemia or Hirata syndrome-like situation. We could not get any reason for this patient. Probably we thought this clopidogrel, which is responsible for this IAS syndrome, and we decided to go for stopping medication with the concurrence from cardiology department, and patient improved a lot. Of course, there are a lot of data are available now. This is little old data in 2016, published in Journal of Diabetes. What they feel that is, if the patient has got IAS, Hirata, we should not start clopidogrel again. This is one data from JCM published in 2020, which also showed the evidence of Hirata after using the clopidogrel. So strong linkage with the HLA, which already discussed, and presentation maybe hyperglycemia, sometimes paradoxical hyperglycemia also you can get. In selected cases or severe cases, you can give steroid also. And for our patient, we started her on little steroid also. Now patient is absolutely fine. She developed another issue is not related to Hirata syndrome. Now, lastly, one simple case is a case of simple hypoglycemia in adrenaline insufficiency. And one data shows in the sensitivity of insulin will increase to 70%. And theoretically, this can produce isolated hypoglycemia. This is one case report. What it showed, a 60-year-old female, and patient had multiple episodes of hypoglycemia. If you see the biochemistry, this was a picture. ACTH is quite low in presence of very low levels of cortisol. Cortisol level was only 0.15, almost undetected, and ACTH is also undetected. Such a situation, you should suspect something in the pituitary, and pituitary showed evidence of empty cellular syndrome. My dear friends, this could be a rare manifestation, but mind you, all these possibilities are definitely you will come across in your clinical practice also. Now, carry home message is very simple. proper history, addressing the symptoms. Is it a neuroglycopenic or adrenal symptoms? You should look into the Whipple's triad, exclude drugs for producing hypoglycemia, and categorize a patient into two: good patient or well patient or sick patients, and appropriate tests. Usually in hypoglycemia test, 72-hour fasting test is the investigation of choice, and after documenting hypoglycemia, you can go for functional imaging. So take-home messages are very simple. You should have a good clinical assessment for picking all these rare situations, but definitely will come across in clinical practice also. Ladies and gentlemen, for the timing I am signing off. Thank you very much. This is my institute, Indian Institute of Diabetes, written in Malayalam.